Rahim. Let's start. I don't think so there are too many people around here, but we'll start and then see if other people would be able to join. So the question was, what is somatic symptom disorder and what actually is in ICD-11 and DSM-5, what terms are used in DSM-5, what terms are used in ICD-11, how to assess these type of patients, and then how to move forward with the management. So I tried to see the different psychiatric classification system currently in use, but of course there is an overlap. Surprisingly, this was very surprising for me that in FCPS examination still the ICD-11 is not used, because the MCQs and other questions which are made are still made from the books which are using ICD-10 and DSM-4. I don't think so there was any question related to DSM-5. Was there any? And
सर ऑक्सफोर्ड से थे ज़्यादा MCQ, so ऑक्सफोर्ड में DSM-5 और ICD-10 का जिक्र है.
DSM-5 or ICD-10 का जिक्र है. So ICD-10 people are still using, and I always have a criticism about it, because when I was in Pakistan, even at that time, I was asking my candidates not to use ICD-10 because it's a very old classification system. And things have changed over the period of past 30 years. In 3 decades, ICD-10 is definitely obsolete, and the confusing terms. Whenever a new classification system is coming up, it's always again tried to simplify the things rather than complicate things. But unfortunately, with this somatic symptom disorder, things are a little bit confusing. So let's try to clear it up. The classification of mental disorders known as psychiatric nosology and psychiatric taxonomy. It represents a key aspect of psychiatry and other mental health professionals, and is an important issue for people who may be diagnosed. Why we use the classification system? One, when you make a diagnosis, you are actually conveying this information to other healthcare
Sorry
professionals.
sir, I'm interrupting you. हमें स्लाइड्स नजर आ रही हैं या मुझे नहीं आ रही सिर्फ?
साइट मैंने शेयर तो की है, दोबारा करूं?
मतलब आई एम नॉट श्योर क्या बाकी सबको स्लाइड्स नजर आ रही हैं? Anyone?
Let's try to share it again. Okay. Can you see it now?
Yes sir, अब आ रही है.
Okay, chalo. Theek. Right. So I was just trying to say that the psychiatric classification system, which is also called psychiatric nosology and psychiatric taxonomy, are important because we want to, again, one, convey what our impression or diagnosis is for the patient to other healthcare professionals. And two, we want to make sure that whatever the management strategy is, again, chalked down to proceed according to the treatment plans, it has to follow some guidelines. So this is important for all of us. And I always say, first make a diagnosis, that management strategies are clear. What we try to do is that we give a diagnosis, but unfortunately, diagnosis is vague, not using any classification system, and then the management strategies are always compromised. So we always move forward to prescribed medication without an appropriate diagnosis. Unless or until we make a diagnosis that, again, prescribing medication is not a very good thing to move forward. So this is one way of going. The most related topic is that you should be able to understand the DSM-5 basic themes, the ICD-11 basic themes. But if in FCPS examination system, the examiners are still using the old classification system, then unfortunately the students get more confused. They are reading ICD 11 because they should be reading ICD 11. It's again new. Now DSM 5 TR is launched as well. So that is the latest version. DSM 5 TR launched about a few months ago, and ICD 11 was launched about a year ago. We are still trying to follow up the things which are about 10 years old, DSM 5, as 5, 7, 8, 10, more than now 10 years old, and ICD 10, which is 30 years old. And if in Pakistan we will stick to that, we won't progress further in psychiatry. We want to make sure that the mental illnesses are clearly defined and elaborated in both the classification system, especially the topics of controversy like personality disorders, somatization disorders, somatic symptom disorder, somatoform disorders, and bodily distress disorder, which is the focus here. And you should read more about this, even if the things are not clear, what I am telling. So I want to make an understanding into difference between the somatic symptom disorder and various classification. This was the task given to me. Now, what are the definition is ICD 11 or DSM 5? Other schemes, terms, usage, classification schemes, cultural differences, historical development, and criticism, of course. So I have hordes and hordes of criticism about these disorders according to the classification system. If you look at DSM 5 mentions somatic symptom and related disorders. That includes somatic symptom disorder, illness anxiety disorder, conversion disorder, psychological factors affecting other medical condition, fictitious disorder, other specified somatic symptom related disorder, and unspecified somatic symptom related disorders. So this is what the DSM-5 says. So DSM-5 has mentioned somatic symptom and related disorders. And somatic symptom and related disorders includes conversion, includes abnormal illness behavior, the old term, includes illness behavior, includes illness anxiety, somatic disorders, and psychological factors, whatever the person goes through during the time of the chronic medical ailments like renal failure, carcinomas, cancers, other rheumatoid arthritis, cerebrovascular accidents, blah, blah. All of those disorders lead to some psychological, again, problems, which could be categorized in a way of a major psychiatric morbidity or maybe the psychological symptoms morbidity. So if it is not fulfilling the criteria, diagnostic criteria of any disorder, then we call it psychological symptoms or factors which are related to medical conditions. But if we can make a firm diagnosis for a person who is suffering from illness related anxiety secondary to, say, renal failure, then that is more authentic, more powerful, and the management strategies are more clear. In ICD 11, if you open up the internet and read about these disorders, they are mentioned under the heading of disorders of bodily distress or bodily experiences. And disorders of bodily distress or bodily experiences include body distress disorder, body integrity dysphoria, and other disorders. So, two main categories come under bodily distress and or bodily experience disorders. One is 6C20, which is bodily distress disorder. It is, again, if you look at this slide, the important component is 6C20 now incorporates hordes of other symptoms like somatoform, somatization, somatic symptom, Briquet's disease disorder, polysomatization disorder, multiple psychosomatic disorder. All of these terms are merged into one, which is bodily distress disorder. So now we won't say Brickwood syndrome. Brickwood syndrome is what? A person presenting with somatic symptoms coming, getting treatment from gastroenterology, neurology, surgeons, physicians, blah, blah, blah. These patients are called revolving door phenomena. So they come, they seek the treatment, they go away, they come back again. Either the compliance is not poor or the response is not good, as you mentioned. All of those disorders are now grouped together in bodily distress disorder, one term. However, the body integrity dysphoria is a different disorder. I will come to that as well. Bodily distress disorder includes all of it, but we have to rule out Tourette syndrome, trichotillomania, dissociative disorders, hypochondriasis, body dysmorphic disorder, which comes under OCD now, excoriation disorder, gender incongruence, sexual dysfunction, tic disorder, sexual pain penetration disorder, post-viral fatigue syndrome, chronic fatigue syndrome, and benign myalgic encephalomyelitis. If we rule out all of these things and still, so we rule out that he is not having Tourette syndrome and he is having some bodily distress disorder, and the patient fulfills the criteria of bodily distress disorder, which is there, of course. I may have a slide for the diagnostic criteria for this. Then our diagnosis is established and we move on for the management strategy. If a patient is coming to you with, say, multiple somatic symptoms, which is bodily distress disorder, but at the same time he's having a tic disorder, or he had a viral infection in the past and a possibility of post-viral fatigue syndrome is there, then of course the bodily distress disorder is not the primary disorder. We have to treat post-viral syndrome, fatigue syndrome, not bodily distress disorder. So for bodily distress disorder, it is essential component that everything happening to a person, as far as the physical aspects of presentation is concerned, is related to mind and not any other organ in the body, right? So this is important. Now, disorders of bodily distress or bodily experiences, what are they? This new broad category replaces all somatoform disorders of ICD-10 and will unite a number of previous separate categories like somatization, somatoform, autonomic dysfunction, and neurasthenia, and some of them I have mentioned in the last slide as well. Hypochondriasis is included among the OCD and group not in the group of bodily distress disorder. So if a person is presenting to you with hypochondriasis, I won't go into the details of it, then he goes into the OCD related disorders. If it is OCD related disorder, then the management strategy is altogether different. So now for people who are having hypochondriasis, the main diagnosis, the top diagnosis is OCD related disorder, and the management is according to OCD related disorder and not like this, the way we were managing them earlier. A new diagnosis of body integrity dysphoria is added, which describes an intense and persistent desire to become physically disabled and accompanied by persistent discomfort concerning current non-disabled body configuration. Now, bodily integrity dysphoria, there is absolute lack of insight, and people feel that their arm is absolutely non-functional. They cannot raise arm, and this goes into such a severity that people are bedridden, they are non-functional, and they have severe wish to die. So, bodily disintegrated dysphoria is an extreme disorder In under this heading, which is categorized separately, but it is intense and severe because the person is so much in suffering that he gives hope, he don't want to live, he is crippled, he is bedridden, and he is doing nothing. So that is a crucial again. So hypochondriasis goes into OCD. The management strategy is according to OCD. Bodily distress disorders, I have named the terms, and it presents with three subtypes: mild, moderate, and severe. We will talk about them again in slides to come as well. Comparison of DSM-5 and ICD-11. So bodily distress disorder, this is the name given in ICD-11. In DSM-5, it says somatic symptom disorder. Both includes the diagnostic criteria is almost the same, one or more of distressing symptoms, excessive attention on the symptoms. So they will keep on repeating about the symptoms. No matter what question you will ask, one way or the other, they come back to the symptom. It's not alleviated by reassurance after clinical examination and investigation. When you tell them that your liver is absolutely fine and there is nothing wrong with your liver, we have seen the ultrasound here, he will still say that my jaundice and my liver is absolutely not okay. So intensity is quite high. Subcategories of somatoform disorders like hypochondriasis, I have mentioned it as removed. It's not anymore here, and they are moved to OCD. Now, they are both categorized in both the classification system. The bodily distress disorders are categorized into mild, moderate, and severe. In mild cases, the management strategy is only psychological. In moderate to severe cases is psychological, pharmacological, and of course, social as well. So the best part is one, you diagnose, two, you categorize them mild, moderate, and severe. Only then the management strategy is clear. ICD-11, so bodily distress syndrome. It is one, severe, which includes multi-organs. It's mild if one organ is involved. So it could be CP type, it could be CP type like palpitation, heart pounding, so cardiac related, breathlessness, exertion, hyperventilation, cold sweats, trembling, shaking, dry mouth, churning in stomach, butterflies, flushing to blushing. Now, more than three symptoms, CP like, cardiopulmonary. It is again considered to be severe, not moderate. Same goes for the GI. Abdominal pains, frequent loose bowel movements, feeling bloated, full of gas, distended regurgitations, constipation, diarrhea, nausea, vomiting, burning sensation in chest or epigastrium. This is again more than three symptoms related to this. You are not able to find any organic cause for it. Ultrasound and other investigations and the physicians have seen, and there is nothing wrong there. Then it is bodily distress syndrome, GI type. And GI type, severe intensity if more than three symptoms. Then MS type, fibromyalgia, musculoskeletal, pains in arms or legs, muscular aches or pains, pains in the joints, feelings of paresis, localized weakness, backache, pain moving from one place to another, unpleasant numbness, or tingling sensation. More than three symptoms of MS, musculoskeletal system, severity is severe. If the severity is severe, biopsychosocial model of healthcare, but not the treatment for MDD. This is different. And then GS type, again, concentration difficulties, impairment of memory, excessive fatigue, headache, dizziness. If you just look at the symptoms, hordes of our patients are presenting with these symptoms. You have to understand that they are not fulfilling the criteria of any other major psychiatric morbidity, including MDD, OCD, and other disorders. Now, these symptoms are they can overlap as well. So if it is multi-organ, like including MS and GI, or it includes CP and GS, or it includes CP, GI, MS, one symptom of each, even then the severity will be severe. And if the severity is severe, then of course treatment is. The crucial point is they have health anxiety and they present with symptoms like this. So all the other related disorders like somatization disorder, undifferentiated somatization disorder, pain disorder, neurasthenia, somatoform, hypochondriasis, NOS, they have all been removed into this one category. I hope this is clear for you. And this slide, I have shown it somewhere else as well. The psychiatric diagnostic and treatment system needs a new paradigm. Now, somatoform is O-form disorder. It could be psychoform, it could be somatoform. Somatoform could be somatic, which is somatization disorder, conversion disorder, dissociative disorder, borderline personality disorder. But all the O-form disorders, if they have bodily distress syndrome and those diagnostic criteria are not fulfilled, then the treatment is with bodily distress syndrome disorders. And we always try to make invisible illnesses visible, which I always say, which is a very difficult thing, that something is not there, but you are trying to make it happening there, that it is there. You understand the pain, you understand the problem, you understand all the associated distress happening socially, psychologically to him, the patient, or the family, and you want to make it visible that this is something which is really actually there and I can see it. It's very difficult for a psychiatrist to see it, but still we make a diagnosis. Bodily distress syndrome, latent class analysis. This was a study which I picked up from some place in 2007. It's an old study, but they have mentioned about the same diagnostic criteria: cardiopulmonary, gastrointestinal, musculoskeletal, general symptoms, and symptoms of one of the above groups. More than four symptoms of the above groups. 1 to 3, yes, moderate. 4 to 5, yes, severe. Relevant differential diagnosis rule out impairment more than 6 months having these symptoms. Regurg, stomach pain, despite taking treatment from the gastroenterologist and all the stomach related medication, the regurgitation and the stomach pain is still there. It is intense, severe bodily distress syndrome. Everything clear so far? We are just
Uh,
two people, but
yes, sir. Yes,
okay,
sir. Very much clear.
okay. अगर
Very much clear.
miss हो तो clear. Now, important
ठीक है
link.
sir.
Important link is predisposing factors, which is biological, psychological, and social. We have to understand that. Genes, childhood trauma, previous diseases, parental illnesses, etc., leads to this. Mostly the precipitating factors are infection or physical disease, physical trauma, emotional trauma, and long-standing stress. So these are precipitating factors. And maintaining factors are they develop the worry, it is there, the gastroenterologist, the cardiologist, despite giving the medications, are not able to correct it. They understand, even the GI people, they understand this is psychological, but they won't refer. They keep building up the medication, they keep giving the antidepressant on a high dose, and the patient won't get better. So illness worry, dysfunctional, CNS sensitization, iatrogenicity, and social factors. All of these things play a role. And fully developed functional disorder, as they say, functional disorder. I will still say that this is not functional, it is actually a distress call. Severe bodily distress complex, management at specialized unit. Unfortunately, we don't have that in Pakistan. Well, we don't have it in a number of countries. It's actually a coordinated assessment plan from a multidisciplinary treatment team, which includes CBT, rehabilitation, relevant pharmacological treatments. So liaison psychiatry come into play. A physician, a surgeon, and the psychiatrist, they should harmonize their treatment strategy, come to one point, then the outcome is good. Usually this never happens. So these people are having chronic ailments. How we'll be able to convince the physicians that whatever you have given in past 1 year time, the treatment for stomach, for heart, for other symptoms was not able to correct it, and you know that this patient is in pain, he's complaining to you time and again, you are giving antidepressant, you're giving antipsychotics, you're giving mood stabilizer, patient is not getting better. What to do about it? So make a team approach. The best management strategy is take physician, surgeon, and other people whose prescriptions he is carrying on board, make a team, make a board, and then intervene, and the outcome will be better. Otherwise, outcome is pathetic, traumatic, problematic. Bodily distress syndrome and somatic symptom disorder. What are the differences between the two? One, diagnosis made in presence of general medical disease if criteria otherwise is met. In ICD-11, better explained by another disease, they cannot be labeled as BDS. So in DSM-5, the basic crux is even the person is having actual medical morbidity, then they will not diagnose it as somatic symptom disorder. They will be, even still, they will be diagnosed as somatic symptom disorder. However, in ICD-11, they have just clear-cut made a distinction. Any physical illness, diagnosed physical illness, you will not say bodily distress syndrome, which is again sometimes difficult because the physicians won't agree with it and they will say, this patient is suffering from fibromyalgia or functional somatic problems and neurasthenia and we want to treat it. But unfortunately, if you keep on treating them, the patient won't get better. Multi-organ system, it's complex. And severity, if it is very severe, then the outcome and prognosis is only good if the people are in a coordinated treatment strategy plan. Otherwise not. So wellness, patient is absolutely fine. Then they develop some kind of physiological phenomena. Self-limiting symptoms appear. They start worrying about their, again, illnesses, cardiac symptoms, and then there are recurrent worrying thoughts about it. They see the doctor, they get the treatment, but they are not getting better, and their illness keeps on getting severe and severe, and persistent disabling somatic symptoms ultimately develop, which leads to complication and difficult management. I have lots of criticism about this diagnostic system. As I mentioned to you, two things in the beginning. One, even if you diagnose that this person is having gastritis, the gastroenterologist will say that he is having gastritis. Now, you are giving again, three-pronged treatment for gastritis, and gastritis is not getting better, then this is not bodily symptom distress disorder. This is complication. So I have reservations about it because the physicians, the surgeons, the pulmonologists, the cardiologists will never come to the term that this patient, they will agree with that this patient is having psychological overlay, but they won't back off with that there is nothing wrong with him physically. They will still say. So we will be having problems with that. Second, unfortunately, the family also lacks the knowledge. And they will keep on insisting that this person needs an endocrinologist or the cardiologist or the neurologist. They go to the neurologist despite seeing the psychiatrist, despite the fact the psychiatrist made the diagnosis, they will say. Till the time the person is so disabled that he is bedridden. And then, of course, the physicians come to their action and try to do something about it. So this is a big criticism, and I definitely feel discomfort about it. Now, the other classification thing, B26, B21, body dysmorphic disorder, is characterized by, you have to read it very carefully because this is tricky. You have to Make sure that it is characterized by persistent preoccupation with one or more perceived defects or flaws in appearance that are either unnoticeable or only slightly noticeable to others. मेरी नाक बड़ी है. अब people will say कि नाक ऐसी ही होती है. I will say no, मेरी नाक बड़ी है. Individual experiences excessive self-conscious. I won't be able to present myself like this if I feel that my nose is big. I don't bother about it, but whatever size my nose is. But these people do focus a lot on that and they stop presenting themselves anywhere. Often with the ideas of reference. So my presentation kar raha tha and the people were talking about my nose. He was pointing out about, and he was putting finger like on his nose. Actually, he was pointing out on me that my nose is big. Now, this is not a delusion, but up to a delusional level. But of course, patients do feel ideas of reference. They are not delusional, ideas of reference. The conviction that people are taking notice, judging, or talking about the perceived defect or flaw. In response to their preoccupation, individuals engage in repetitive and excessive behaviors that include repeated examination of the appearance or severity of the perceived defect or flaw. So I will keep on seeing my nose. I will move back to my presentation screen where I can see myself and then I will keep on seeing my nose. Okay, is this okay? Is it fine? Is it working okay? So this is unfortunately where it is. The symptoms are sufficiently severe to result in significant distress or significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. Exclusion, anorexia nervosa, bodily distress disorders, which we have mentioned earlier, and concerned about the body appearance, which is body, again, actual disfigurement. So the codes are 6B21 and 6B21 is body dysmorphic disorder with fair to good insight. 6B21.1 body dysmorphic disorder with poor or absent insight, and 6B21.2Z, which is unspecified. It's complex. Now, body integrity dysphoria is characterized by intense and persistent desires to become physically disabled. Then people start feeling that they are so much having a problem that they, as I mentioned to you earlier, that they are bedridden, they lock themselves up into the room, they don't want to go out, they don't want to interact with people, they don't want to see doctors, they don't want to do anything about it, and ultimately they are bedridden. So it is a complicated situation. There are multiple research papers available, and I will definitely ask you to go back and read them. That's it for today. Now, any question that you want to ask, I'll be happy to respond.
Yes sir, मेरा एक क्वेश्चन है.
Sure.
सर वैसे तो आप
वैसे तो
हमेशा
आज
कहते
की
हैं.
अटेंडेंस का कसूर आप हैं. अच्छा, मेरा इतना टाइम आपने लगाया अटेंडेंस देखें. अच्छा, हाँ बोले.
सर नहीं, आज वीकेंड है ना, वीकेंड पे अटेंडेंस कम होती है हमेशा.
फिर
ट्रस्ट
मुझे आया कि तो क्लास फिर मैं जाने देना था ना. मैंने भी इतना ट्रैवल कर.
थैंक यू सर, थैंक यू सो मच. आपने स्पेशली टाइम निकाला है. रियली वेरी थैंकफुल फॉर दैट.
अच्छा,
अच्छा.
चलो बोलो. हाँ.
और नहीं सर, दिस इज अ वेरी इम्पोर्टेंट टॉपिक. सच में आपने बहुत अच्छा समझाया है. ट्रस्ट मी, ये बहुत आप इसके बहुत व्यूज होंगे. डोंट वरी.
ओके. सो
अच्छा
क्वेश्चन क्या है?
जी सर, मेरा क्वेश्चन सर, अभी वैसे तो आप हमेशा कहते हैं कि असेसमेंट करें और डायग्नोसिस बनाएं, मतलब मैनेजमेंट, जैसे आप हमेशा कहते हैं असेसमेंट, रीअसेस द पेशेंट, रीअसेस एंड मेक डायग्नोसिस. ऐसे अगर हम मतलब देखिए, हम पेशेंट को रीअसेस करते हैं, डायग्नोसिस बना लेते हैं, जैसे आप इसमें कह रहे थे कि उसमें एक कोऑर्डिनेटेड अप्रोच चाहिए अगर हमारा ये डायग्नोसिस बनता है फॉर मैनेजमेंट. अच्छा, अब ये तो आइडियल सिचुएशन है ना, जैसे एग्जाम सिचुएशन में हमने आंसर करना है, लाइक आइडियली व्हाट शुड बी डन. लेकिन अगर हम ऐसे बात
Ideally,
करें.
this should be done. In the exam, you have to say the same thing.
Yes, sir.
You have
Exactly.
established the
Exactly.
diagnosis.
Yes,
Then
sir.
it is a team effort, team
Hmm.
approach, lies on psychiatry. अब दुनिया में lies on psychiatry की specialty बन गई है,
जी
ठीक है?
जी.
और कुछ मुल्कों में lies on psychiatry के एग्जाम भी post FCPS लेवल पे हो गए, मतलब post regular psychiatrist. So जैसे child psychiatrist बनते हैं, so you do 5 years of residency and then
Hmm.
you do child psychiatry. Same is
Hmm.
happening with lies on psychiatry. So it's
Hmm.
5 years of the psychiatry and then 2 years of the lies on psychiatry. And this is what the job of the licensed psychiatrist is,
Hmm. Hmm. Hmm.
that he will try to coordinate the efforts, because most of these patients are presenting in the medical field.
Yes,
Very few
sir.
with the psychiatrist, especially if it is complicated and bedridden mind, then it has to be team effort. In
Uh,
exam, the answer should be the same.
एग्जैक्टली मैंने वो मैं बात बिल्कुल समझती हूँ आप वो, लेकिन अभी जब मैं क्वेश्चन करने लगी हूँ ये प्रैक्टिकल जो हमारी डेली ओपीडीज होती हैं उससे रिलेटेड है कि कर लूँ, मतलब ऐसा क्वेश्चन कर सकती हूँ
Sure.
सर. तो जो पेशेंट्स आते हैं वो इतने स्वेट स्ट्रेस में होते हैं और अटेंडेंट्स भी मतलब हाईली एक्सप्रेस्ड इमोशंस होते हैं और मैनेज नहीं हो रहे होते, तो मतलब उसमें हम क्या व्हाट कैन वी डू, मतलब ये ठीक है, मैं ये बात आपने जो सारी बातें की हैं कि एक कोऑर्डिनेटेड
So
अप्रोच चाहिए.
what will I do? Of course, I will go for this, right? What will I do? Of course, I know
Yes.
that getting hold of the gastroenterologist. So what I do, I usually write a note, right, on the side that this patient is presenting this. This is my diagnosis, and I
Hmm.
send them back to the neurologist and gastroenterologist. यहाँ पे भी मैं यही करता हूँ. I ask them
Hmm.
to review their medication, reassure the
Hmm.
patient, taper off their irrelevant medication, and then lies on with me.
Hmm.
The success rate is very less, but
Hmm.
still have to try to do that first. If that fails, and the physician is not willing to do anything about the medication, बहुत सारी जगह पे
Hmm.
यही फिजिशियन इनकार
Hmm.
कर, मेरी दवाई बिल्कुल ठीक है, चाहे उसने साइकोट्रोपिक की दी हो, वो कभी मानने को ये तैयार नहीं होता कि उसने गलत दवाई
Hmm.
दी. It's a common phenomenon, which unfortunately
Hmm.
is traumatic for the patients out. Then I
Hmm.
have to educate the family. This is what the opinion is.
Hmm.
This is what the diagnosis is. This is what I am writing on a piece of paper and giving
Hmm.
it as a proof that I
Hmm.
am firm. I have firm conviction about the diagnosis.
Right.
And this is the management plan, that you will taper off the rest of the medications. You will
Hmm.
rely on medications which are related only to this disorder. You will be
Hmm.
incorporated with the psychological intervention, and the social intervention is 1, 2, 3, 4, 5, 6, and you have.
Hmm. Okay.
This is what we have. So, actual in real life situation, first you try, send them
Hmm.
back to the GI people, cardiovascular, and other neurologists, whosoever is involved in care. Tell them about your diagnosis and the management strategy, and see how they
Hmm.
respond to it. If they respond
Hmm.
positively, then it will be a good thing. All you have to do is to make a combined meeting with the patient. Neurologist भी आ जाए, psychiatrist भी बैठ जाए, physician भी बैठ जाए, और तीनों मिलके patient को देख लें, clarify कर दें, उसको reassure कर दें, उसको management plan बता दें, और efforts शुरू कर दें, which helps a lot,
Hmm.
ideally. लेकिन अगर वो नहीं होता तो of course we have to fight all by ourselves. मैंने तो पहले बीच में slide में mention कर दिया. We are actually trying to make invisible the visible, which is sometimes difficult. But why we should
Okay.
lose hope? We have lots and lots of things that we can do,
Hmm.
right?
Right, sir. Right.
चलो, हो गया.
Thank you.
You are more than
Yes,
welcome.
sir.
Now I have to leave it in 10 minutes time, so I will stop this presentation. Make sure
Thank you, sir.
that attendance is appropriate when you give me a topic, something difficult like this. Okay?
Sir, I'm really sorry. मैंने तो
कोई बात नहीं.
circulate
तो
same
मैं
किया
तो
था
बार बार
जैसे मैं पहले
कहता
करती
रहता
हूँ.
हूँ ना, लोग YouTube पे तो देख लेते हैं लेकिन फिजिकल प्रेजेंस में लैग करते हैं. चलो, बेस्ट ऑफ लक, राइट?
चल, थैंक यू
Oh,
सो मच
thank
सर.
you. Take care. Allah Hafiz.